All right. Good morning, everyone, and thank you for having me. My name is Rishi Bansal, and I'm a first-year MD student here at McMaster. And today I'll be presenting our project, Frontline Connect, evaluating a virtual technology program to enhance patient and provider communication during COVID-19. And before I begin, I have no financial conflicts of interest to disclose. So as we know, hospitals have significantly reduced in hospital visitation since the very beginning of the pandemic, and this has not come without its challenges. A lot of these have been related to communication between care providers, between patients, between them and their families, and it's created some tragic situations where patients are kind of left alone in hospitals without many people to talk with. What we do know, however, is that healthcare providers already use their personal devices for patient-related communication all the time, whether it's through text, phone call, video call, etc. And this was also the case during the pandemic. So the Frontline Connect Canada, or FCC program, was designed to address these communications challenges by providing free data-enabled devices to healthcare staff in hospitals and long-term care settings. A screen cap of our website is provided here. The objective of this project in particular was to identify the needs of professionals and then use that info to inform the program rollout, and then see if those needs were eventually fulfilled and any barriers that they faced in the process. So let me start by giving you a brief overview of the program. Frontline Connect Canada was created by an interdisciplinary team of students, physicians, technologists, and social entrepreneurs, and it was informed by existing virtual device guidelines for device use across hospitals in Ontario. The devices themselves were sourced from community partners and corporate partners, and telecommunications company provided SIM cards and cellular data for all of the devices. The actual sites themselves were identified by request forms on the website, as well as from personal connections to our team. The volunteer site leads at each site were identified and then provided with a custom user manual that was created by user experience experts to make the process as easy as possible. We worked closely with leadership, IT departments, and administration to ensure that we had approvals the entire way and that privacy concerns and all of these other kinds of things were adequately addressed. And some of the sites, especially the ones that we're going to be reporting today, use their hospital IT departments in particular to help set up the devices and make sure that everything was secure. This study in particular provides data from Hamilton Health Sciences and the Scarborough Health Network. So our study was a multi-center retrospective program evaluation study of the FCC program using a convenient sample of user surveys. We recruited participants via site champions, so the site leads that we previously mentioned, through emails, through personal communications, and through leaderships within the hospital departments. The needs assessment survey and exit survey were sent to all hospital workers, regardless of whether or not they had used a device or in a particular department. Whereas we also provided post-use surveys, which were intended to be filled out immediately after a device was used. And what we were really looking for here was, were the anticipated needs in the needs assessment survey, how well do those match up with the actual needs and actual use cases that were identified after the program was implemented? What was the user experience and satisfaction, the reasons why people use the device, and finally, strengths and areas for program improvement. The timeline was as follows. We began the needs assessment in May and then collected that during that month and used the information that we received to inform the program rollout, which began in June. The post-use surveys were provided as a package with the devices, and these were completed between June and August, at which point they were stopped. And then finally, an exit survey was administered in November and December of 2020, and then data collection was completed. So looking first at the needs assessment survey, we had 139 respondents to this survey, mostly from the emergency department and the ICU, from nurses and MDs. The graph on the right shows that personal device use during an average 5 working days increased since the beginning of the pandemic. So at that point, it had really only been a month or two, but already we were hearing stories of physicians who were using their data plans up to video call in families and to conference with caregivers and, contact people's power of attorney, set goals of care, all of these different kinds of uses. This was already happening even by May, it was rolling around. And over 60% of the people who responded to the survey said that their facility had no dedicated devices. The remaining 40%, many of them referred to the nursing station phones that could be used to call family as the only device that was available to them to contact people outside of the hospital. And so if they did have a device, they reported they would use it to video call families, use it to set goals of care, and do all of these other tasks that normally they would be able to do with a family member that was present. We also asked respondents to identify some initial concerns that they might have if this program were to be rolled out. And initially, a lot of this was related to IPAC concerns and who's responsible for the devices, how they would be cleaned down, who would put them away. They identified that lots of team members are responsible for a considerable amount of clinical work, and so no one really has enough time to be taking on these additional tasks. Staff were also worried about family members' reception, so the possibility of the family being unable to use the technology, and also worried about lots of call requests from family on top of the clinical work. And then finally, privacy and confidentiality also featured as concerns. However, these were addressed by speaking with the hospital's IT departments and the leadership. In the post-use survey, so these were collected immediately after the devices were used. Overall, they rated the utility very highly at 9.7 out of 10, and ease of use was also a 9.6 out of 10. So all of this data came from use in the emergency department and mostly by social work as opposed to the MDs and nurses who had responded to the previous survey. We found a lot of benefits. So the device worked, they served their purpose, they helped build rapport and clarify histories in many cases. In one particular case, we had a report of somebody with a suspected COPD exacerbation who has then had to consider for a pulmonary embolism after discussing with the family. And this is something that would not have been possible without the use of these devices. There were some challenges, however, in setting up a Zoom call, for example. This required some texting from the personal device to the family at any rate. So they suggested if some kind of text messaging or other functionality was available on the device, that might have been useful. And they also identified that it was difficult for staff to kind of always be present to hold the device right next to the bed. So they might benefit from some kind of lap tray or other supportive device to hold the iPad or hold the phone. In the final exit survey, and this was collected again in November and December of 2020, and it was provided to all providers at hospitals where the program was offered. Respondents mostly ended up coming from the emergency department, and again, mostly from nursing and social work staff. And what we got in some open text responses, that staff burnout contributed to the relatively lower response rate during the second wave of the pandemic, which was beginning at that time in December, as opposed to the initial needs assessment, which had quite a few more responses. In this case, 40% of the respondents had not actually ever used a device, and so the average user experience score was lower at 6.9 out of 10 versus the previous 9.7 out of 10. However, we did find that the use cases aligned well, and in the needs assessment, people were able to pretty clearly identify what they would use these devices for if they had them. The only additional one was adding translation services as another use case that featured fairly prominently. And then in terms of proportions of usefulness and usability, this chart at the bottom right displays people who use the device. And as you can see, most who did believed it to be useful, easy to use, and noted that they would use it again to facilitate this kind of communication. Finally, there were some barriers to device use that many respondents noted in the open text responses to the exit survey, as well as the post-use survey. So the first was actual difficulty in using the devices. There were many cases where the family did not have a compatible device or were unfamiliar with the technology. Sometimes there was unreliable internet in the hospital and poor sound quality on some devices. And if the hospital IT department had restricted access to other apps on the device, sometimes they were unable to access browsers or other features of the device itself that might have been useful. Next was device location and availability. So sometimes devices were found to be missing, or they were not put back in the right place, or they were left uncharged. And this proved to be another barrier that prevented some people from using devices, even if they did want to. Third was time. So as mentioned previously, there's lots of folks who are really busy with clinical work, and it takes time to use the different apps, takes time to set it up, takes time to facilitate those conversations. So that kind of proved to be a barrier throughout the process and was fairly consistent. Fourth is staffing limitations. And again, this is also related to time. Social work ended up becoming very much the champions of this program within all of the departments where it was rolled out. But social work was not always available. And so other staff were often confused about who was going to be responsible for the devices, who would be using it, and who would be championing it. And finally, there was a perceived lack of need at some point. So the post-use survey was administered in June, July, and August, where COVID cases had been fairly low. Hospitals had actually started to open up some visitation to family members. And so the perceived need for these devices decreased, although we did start to see some increase again in the exit survey in December once visitation once again became restricted. So finally, there's 4 kind of key points that I'd like you all to take away from this presentation. And first is that this program was useful in facilitating virtual communication, but there were some logistical challenges. So I think this study really provides a use case for these kind of devices and this technology being accessible within hospitals to care providers, because it really can help facilitate that virtual communication in situations where it otherwise might not be possible. The perceived challenges that were prior to implementation were actually not a big concern. So IPAC and privacy were very easily dealt with by the team, but other more important concerns like staff workload and time constraints continued to feature as issues. And these were likely magnified due to the pandemic. Folks had increased cognitive load, higher patient volumes, higher acuity, needed additional time for PPE, et cetera. So the concerns that were identified were probably greater than what they would be in a non-COVID time. Site champions in particular were a very positive workplace facilitator, but again, faced some resistance from staff. And then finally, the program could be improved with additional training, some dedicated staff, and hands-free stands to logistically facilitate the devices. And that's all. I'll be happy to take any questions at this time. Thank you.